Okay, good evening. Welcome to the Human Services Committee, and Happy New Year to everybody. We're starting off a great new year. We haven't had too much snow dumped on us either, only a little sprinkling, so far so good. Anyway, so it is January 10th, 2023, 5:30 p.m. The Zoom meeting is being held at https://town of Barnstable -us.zoom.us/j/87803676684, meeting ID 878-0367-6684, 833-548-0276, US toll free / also 833-548-0282, US toll free, and also 877-853-5257, US toll free, and 888-475-4499, US toll free. This is meeting ID 878-0367-6684. I am going to call the meeting to order. Carlos Barbosa.
Yes.
Yes. State Representative and Committee Member Steve Siros.
Exaro's present.
I'm sorry for the mispronunciation. Committee Member Liz Robideau.
I'm here. Yep.
Committee Member Kim Crowder.
Here. Good evening.
Hi. Committee Member Scott Fitzgerald, and also Vice Chair.
Yep, present.
I don't think I've left any of the committee members out other than myself. Cheryl Powell, Chair. We do not seem to have Megan. Is she expected soon or not able to make
it? Madam Chair, she just recently sent an email within the last 5 minutes to the committee saying that she was unable to attend tonight, and she apologizes for any inconvenience to the committee members.
Okay, wonderful. I hope it's nothing serious, and thank you for letting us know that, Megan. Okay, so the membership is a standing item. We do have one person I know who is interested and will be applying for if we get the alternates. I think we already have a full commission, so I need to get those alternate positions up and running. I did send a notice or a request to the council, and we'll see where that is. Tonight, we have other things on. I just bounce and knock a couple of them off. Anyone who has not done their conflict of interest training, please do so. If you're not sure, contact Cynthia Lovell. This is going to probably be our last major speaker, I hope, or set of speakers, because we need to get down to formulating this plan. And we have enough information on the baseline, I think, in order to try to get something together, at least for this year. Unless if anyone objects to that, please say so. But I think more working on the next membership, our next meeting. Anyway, I'm going to go back up. We are pleased tonight to have the Duffy Health Center, which covers several different areas. And I am going to turn over to Sarah Grambach from Duffy Health Center. If you could just state your position and introduce your other speakers and their positions, please.
Sure, thank you. Hello, my name is Sarah Grambach. I'm the Director of Development and Community Relations at Duffy Health Center. I am joined this evening joined with Aaron Russell, who is our Director of Behavioral Health, and Daniel Rodriguez, who is our Director of Substance Use Disorder Treatment Services. I have a slide deck, if I can go ahead and share my screen and bring that up. Okay. See if I can get this full screen.
And could I also, is it okay that the slides that we see tonight, are you able to send those to us so that they can be included in the information packet?
Yes, absolutely. I was going to ask that question. I can share them with Ms. Lovell, and is that the appropriate process?
I believe, is that all right, Cynthia? I believe that's perfectly fine, but I'll do.
Absolutely, yes, absolutely. Send them right to me.
Great, thank you. So thank you. It's nice to see you all. Hello, Representative Zaros. It's nice to always see you and your smiling face. Thanks for being here, everyone. As I mentioned, my name is Sarah. I'm joined with a couple of my colleagues tonight. Cheryl and I spoke one-on-one last week or the week prior to get a sense of the charge of your committee, specifically related to the deliverable that you all are working on for the town council and town manager, organizing different human service agencies and organizations to come before you. My words on kind of a fact-finding mission to really understand some of the systemic issues that are impacting not the residents of the town of Barnstable, but as you'll see in our presentation, our work is really touching patients and clients across the Cape. We welcome any questions. I know I think we've got plenty of time to get through my slides as well as Danny and Aaron's talking points as well, but certainly welcome any and all questions from the committee this evening. Also in follow-up from this meeting, if you all have questions as you're putting your documentation together, please don't hesitate to reach out. Just briefly, I just kind of want to kind of level set who Duffy Health Center is, who we serve and what we do, which is words you'll hear me often, probably say often throughout this presentation. Our mission is to provide equitable, integrated primary health care and support services for people who are experiencing homelessness or who are at risk for homelessness on Cape Cod. Quality of life for vulnerable and marginalized populations through community collaborations, leadership, and advocacy. And we'll show you some of the ways that we do that throughout this evening. I would apology, and if I could take a moment to kind of define that terminology, which is we refer to people who are experiencing homelessness. We don't refer to them as homeless. We refer to them as experiencing homelessness, much like we would call somebody, a person who has diabetes, not a diabetic. That is important from a stigma perspective, because we're trying to recognize that homelessness may be a point in time and not a defining factor of a person and their lives. The other piece is at risk of homelessness. We serve patients who are truly homeless, who are living on the street. They are in a shelter, they are in a tent. But the majority of the patients that we serve across the Cape are those who, what we call housing unstable, which are people who may be living in a winter rental. They may lose their housing, in the summertime. They may be doubled up. Another way of saying that is couch surfing. They may be living with friends, kind of piecing housing situations together for themselves or for their families. That's a significant population of patients and clients that we serve. Just a brief history. We started in the NOAA shelter, as we say, a clinic in a closet at the NOAA shelter, which is now the St. Joseph's House, where a physician and a nurse practitioner visited the shelter on a regular basis because our folks in the shelter system and on the street were very marginalized from a lot of human services, including healthcare at that point in time. We were incorporated as a 501c3 in 1997. We received our first Healthcare for the Homeless funding through the federal government in 2002, implemented our Housing First case management program in 2005, which I'll talk more about in a second, licensed to provide mental health services in 2006, and in 2017, we're now located at 94 Main Street, a stone's throw from Cape Cod Hospital, if you are not familiar with where we're situated. So we talk about the Duffy Healthcare services and other services that we provide at 94 Main Street as sort of this three-legged stool: the bio, the psycho, and the social. As we say, we were integrated before integrated care was cool, and that's important. One, because it demonstrates sort of that early vision of providing care under one roof and why that's important, not just for patients who are experiencing homelessness or unstably housed. Frankly, it's the best model of care for patients. And so early on, we integrated our model under, at one point, we were at the corners of Camp, Lewis Bay, and Main Street, and we would lose patients going from their primary care visit to their behavioral health visit across the street. So that was part of the impetus of coming under one roof and really that integration under a single roof was the impetus for that. So this biopsychosocial model is not unique to us. It is a community health center model. And a few of the service lines that we provide, primary care, as I mentioned, is our largest service line. We have physicians, we have nurse practitioners, and a full staff of nurses and medical assistants. We also provide medication-assisted treatment for those who may have diagnoses of substance use disorder. We also have a hepatitis C and HIV treatment program and chronic disease management programs. Behavioral health, Erin and Danny will dive further into this, but at a high level, we offer substance abuse counseling, mental health counseling, psychiatric services. We have a full-time psychiatrist on staff. We have 1 and now growing to 3 psychiatric nurse practitioners. For those of y'all who are familiar with the healthcare landscape here on Cape Cod, psych services, mental health services are very challenging for people to access. So that's a real badge of honor for us and being able to provide that under the roof. From a case management perspective, this sort of social component is really significant, not just for our patients and clients, but in general. We say when a person presents to Duffy Health Center for services, they're sort of triaged through depending on what their need is, who they meet with first, whether it's a case manager, whether it's someone in our connections department, which handles insurance and so forth. But it's really the first question is to ascertain what their needs are. Do you have somewhere safe to sleep tonight? When was the last time that you ate? Which is really important because we need to understand what those sort of psychosocial issues are going on with the patient to be able to connect them as soon as we can to the services that they need, whether they're provided under our roof or whether we need to refer to either other clinical services or other human services that may be able to meet their needs. Housing First case management has been around for a while now. You may have read an article in the Globe recently hailing, I think it was Finland. It was one of those countries up there in Scandinavia that they're achieving 0% homelessness through the Housing First model, which is beautiful. And I imagine with socialized medicine and other sort of socialized human service opportunities, that they're able to achieve that much more readily than we are here in the U.S. But the Housing First case management model has been around for a while, and essentially the net of Housing First is that these are going to be my words, but we have to have a roof over our heads in order to be able to take care of anything else. If you don't have somewhere safe to sleep at night, or you don't have somewhere safe to take your children that night, everything else is secondary, right? Your mental health is secondary. Your substance use issues are secondary. All of those are secondary. So the goal is to put a roof either temporarily or with an idea to move them into permanent housing for whatever their circumstances may be is really imperative. I think that's important for this group to know as you further understand some of the challenges that are impacting patients related to housing and housing stability. Medical case management, case manager of the day, as I mentioned, are those folks who are on the front lines to say, what is it that you need, Sarah, when you show up at Duffy Health Center? We also do outreach to the streets, camps, and shelters. We have a staff of outreach folks. We also collaborate closely with a handful of staff over at Housing Assistance Corporation who also do outreach. Danny will talk in more detail around recovery support, so I won't spend time on that here, but also another important piece of our work is spiritual care. We have a full-time spiritual care provider who works with our patients and clients as well as with our staff, and she is a leader on our suicide prevention efforts, which Erin will talk about as well. From a high level, our budget, our FY23 budget is $12 million. Our fiscal year is July 1 start, so we're halfway through that. Our revenue stream is approximately 45% grants, which I'll talk about more in a second, 45% reimbursement, which is a reimbursement for patient services, right? Patient service revenue, 5% fundraising, and then 5% other income. Our payers, about 65% of those are Mass Health or our Commonwealth's Medicaid program. We do have 50% of our patients who are Medicare. That is because they are what we call dual eligibles, meaning that there is some sort of disability associated. Our folks who are experiencing homelessness typically don't live very long. And so oftentimes our folks are getting Medicare because they're dual eligible, not because they're old enough, because they often don't reach the age of 65. Connector is the Mass Health marketplace products, and then approximately 10% of our folks are uninsured. And then our makeup, this is not unique to Duffy, but similar to other community health centers, our federal grants make up about 65%, and then the state makes up the rest with a few other miscellaneous grants in there as well. Danny will definitely go into more detail around relationships here. As you all know, as members of our community, as elected officials in our community, we're unique here on the Cape. As I like to say, whether we like it or not, we have to work together. There's advantages to living in a community like ours. In that we have a regional county government, we have a lot of interested parties at the table who are collectively interested in these 15 towns and the people who live here. So that integration into community partnerships is really key, as you all know, and we make significant inroads and have been doing this for a really long time. So some of those examples are the Regional Network on Homelessness. I believe some of the folks involved in that work have come before this committee. Primary healthcare and community health centers. We have partnerships with the other sister health centers here on the Cape, as well as Martha's Vineyard. And then our state association is the Mass League of Community Health Centers, which is an incredible resource for us. We also have associations both here locally and across the state with regards to behavioral health and mental health, as well as partnerships and presence at the Regional Substance Abuse Council. I believe Danny is the co-chair, current co-chair of that council. We also have some town partnerships, which he can also share more about in relation to our boots on the ground for substance use out in the community. So just briefly, the causes of homelessness. This is a quote from James Wright. It's a housing problem, employment problem, demographic, social disfiliation, mental health problems, substance use, family violence, cutbacks in social welfare, the decay of the traditional nuclear family, and a problem intimately connected to the recent increase in persons living below the poverty level, as well as others. So really just showing that it is an ecosystem of issues that impact patients. I think I'm not alone in saying, we hear stories, not just in our work, but people in our community who are living paycheck to paycheck, and then 1 month it doesn't work and they're on the street. It is really that close for many people in our community, and are impacting our folks who are living and working and trying to be a part of our community and raise families here on the Cape. I'm not going to spend a lot of time because I'm going to share this deck with y'all, but there's something called the point in time count, which happens annually across the United States of America, and it happens in the winter to get a sort of true count of people who are living on the street. In 2022, about 583,000 people were experiencing homelessness. I would offer there's more, right? Because you're trying to get your best count. So that's the actual number of people that were counted at that point in time. 60% were staying in a sheltered location, 40% were not. And we consider unsheltered locations, we call that not suitable for human habitation. So that's a tent, it's a car, it's on the street, and so forth. Another important data point that I would like to drive home is that people of color, people who are identified as Black, African American, or Indigenous, are significantly overrepresented in our homeless population. So, for example, people who identify as Black make up approximately 12% of our total population in the U.S., but they make up 37% of people who are experiencing homelessness, and 50% of people experiencing homelessness who are as members of families with children. And it's a stark data point that I wanted to share with you. I won't go into the mass data in great detail. This will be here for y'all to read. In 2022, we had just north of 15,000 people living unsheltered. In 2022. I think we'll probably have the point in time count in 2023 sometime in the next couple of months. So who is homeless on the Cape? These are individuals and families from all 15 towns. We often refer to people who are experiencing homelessness on the Cape as the hidden homeless. I would offer that people may see homelessness more acutely in the downtown Hyannis area for a host of reasons, not the least of which is that most human service agencies are on the tax rolls in the town of Barnstable, as you all know. But we refer to it as the hidden homeless because there are so many more people out in our community who are truly experiencing this. So our point in time count in 2022 was 343. It was up from 21, and our rise in unsheltered in 2022 was significant, primarily because our shelter had to depopulate because of COVID and has not returned to their number of beds that they were hosting clients in prior to the pandemic. So we serve just north of 3,000 patients. This is universal data set is how we report our data to the federal government. These are 2021 numbers. We'll have our 2023 numbers here in a couple of months. But we hover around 3,000 patients. As I mentioned, we have a broader definition of homelessness here, which include our neighbors who are unstably housed. We serve the entire Barnstable County, entire 15 towns. Approximately 45% of our patients come from the town of Barnstable. 20% from Yarmouth, 10 from Dennis. This is probably not surprising to you, given that Barnstable, Yarmouth, and Dennis are those mid-Cape towns that have a higher year-round population than, say, Truro, for example. Our demographics from 2021, a significant number under the federal poverty level. We've talked about this already, so I won't go into detail. To share a little bit more about the Duffy staff, we have just under 100 people working full-time and part-time. I would offer that our folks have been doing social justice work since before social justice became a thing or a bigger thing in the summer of 2020. So our mission are to take care of people with dignity and respect, without any judgment of where they've been, who they are, and what they've done. It's a really remarkable group of people, and I'm proud to call myself a part of the Duffy Health Center staff. It's just an extraordinary group of people. Sensitivity to cultural and ethnic diversity is incredibly important to our staff as well. Understanding, as I mentioned, homelessness is caused by a combination of barriers and personal vulnerabilities. And Danny and Aaron can share a little bit more about that. Meeting our patients and clients where they need on any given day. Our philosophy of care, housing first, trauma informed, recognizing that a number of our patients have had significant traumas throughout the course of their lives that have informed where they are in their lives currently. We follow a harm reduction approach to substance use, and we use motivational interviewing techniques to help better understand patients and clients and what their needs are and how we can best serve them. So our philosophy is to partner with committees, organizations, other agencies to come up with some systemic solutions to end homelessness. As I say, which may or may not be popular, but I haven't said this in front of my CEO. In my world, I would love to see Duffy Health Center out of business in 5 or 10 years, right? We'll have done our job because we solved those problems and we no longer have to be here to take care of people in our community. Wouldn't that be a beautiful thing? And we're going to do that by partnering with committees like yours, the town council in Barnstable, our county officials, local and national level. This is really an ecosystem of being able to come to the table and truly make an impact. One final thing that I will note here, you'll see this photo of our CEO, some of our staff, and our consumer advisory board members. It is incredibly important to us at Duffy that our patients and clients have a seat at the table to be able to guide our work and tell us what we're doing right, which happens sometimes, and what we're doing wrong happens a lot. They're never shy of giving feedback. And that's incredibly important for us so that we are not doing our work in a vacuum, because we would not be serving our patients and clients in the best way that we can if they did not have seats at the table. So we have a consumer advisory board. You'll see here we have 4 members of our board of directors who are either former or current patients and clients that are at the table guiding the work every single month that we're meeting as a board of directors. Thank you for listening to me. I love to talk about Duffy. It's one of my favorite things. I appreciate your time. I will pass it over. I will stop my screen share and I will pass it over to my colleague, Erin Russell. Thank you.
Thank you. Welcome, Erin.
Hello. Thanks for having me here to talk about, I'm going to talk about the behavioral health services that we offer at Duffy. Like Sarah said, I'm the director of behavioral health. So the behavioral health department offers trauma-informed services and programming to address mental health and substance use disorders. Our programming includes, like Sarah said, psychiatry, individual group therapy. We have some specific programs that I will talk about more, like our Bridge program, our Pathways program, and we offer some in-reach to the Barnstable County Correction Facility. Our behavioral health services are an important part of our integrated care model. We work with our internal departments and community agencies to wrap around our patients and work on treatment goals to decrease mental health or substance use disorder symptoms and behavior. Referrals to our behavioral health programs occur from our internal departments, such as medical and case management or SUD department. They also include self-referrals and community referrals. We collaborate and partner with several community agencies. Some of those are, we collaborate with Cape Cod Hospital. As previously stated, we have a Bridge program. The Bridge program collaborates with Cape Cod Hospital and focuses on individuals discharging from the hospital to ensure they receive clinical and psychiatric support after hospitalization. The patients will have an appointment with a therapist and a psychiatrist to continue medication management that began at their hospitalization, and the therapist will work with the patient on safety planning or acute needs to keep the patient in the community and to assist with them not being re-hospitalized. Our in-reach program to Barnstable County Correctional Facility, we have a clinical staff member who meets with individuals that are currently in the Barnstable County Correctional Facility to assist with their discharge planning. The clinician goes out twice a month to assess their behavioral health needs, their substance use or medical needs. They work with the team to use brief intervention to connect these individuals to services within Duffy, such as primary care, behavioral health, our office-based addiction treatment, or they make referrals to appropriate services and agencies that are needed. Sarah talked briefly about our internal suicide prevention resource, which we call Pathways. It supports our behavioral health patients who have increased risk for suicide. They could have a suicidal ideation, previous suicide attempts, or increased risk factors that don't meet criteria for a high level of care. The clinical staff assesses patients and refers them to this resource. The Pathway program connects these individuals with a case manager who provides outreach and support as needed for this individual. They use compassion and empathy to reinforce the person's treatment plan, and they assist the person to engage in treatment to hopefully decrease and eliminate suicidal ideation. Those are some of our behavioral health programming, and I'm going to pass it over to Danny, who will discuss more programming at Duffy.
Welcome, Danny.
Hello, good evening.
Do you have to be called Danny or Daniel?
You guys are friends, so you can call me Danny.
Welcome, Danny.
So it's a privilege to be here, and so nice to see at least one familiar face. So thank you again for having us. And I am excited to be able to come and to talk a little bit more about not just our substance use disorder services at Duffy Health Center, but also the partnerships and continued relationships we have built and continue to build with our key stakeholders, community partners and colleagues, obviously across Cape-wide. Just to give a little bit of, a little bit of a backstory here. I've been with Duffy Health Center about 3.5 years. Substance use disorder services and treatment has always been a staple of Duffy Health Center. And when I started, our office-based addictions treatment program really was leading the charge with regard to providing medication for opiate use disorder on Cape Cod. It is actually the only credentialed facility to serve 16 plus, so adolescents as well as adults experiencing opioid use disorder. So that's always been for us kind of a part of our fabric at Duffy, is being able to support our patients and our community with access to medical care for their substance use treatment. This is something that I am both excited and at times sad to share, but in the past 3 years, we've gone from a staff of approximately 8 or 9 to approximately 25 staff members, which speaks to our community's need in general, as well as obviously the necessity to think outside of the box and connect with other agencies to create more comprehensive treatment programs in a way that really meets the acute need of our community, which is ever changing. We know that, and if we stay stagnant, that is something that we find ourselves being way behind the times with the trends around substance use. So in addition to our office-based treatment program, our Duffy Health Center has a fairly robust set of staff members and a real dedication to working with and alongside individuals with lived experience from a peer perspective. So we have a large recovery support navigation team, which are, again, folks with lived experience who are in sustained recovery, who are supporting our community members and patients with accessing brief intervention care, linkage to treatment, returning back into our community with the hopes of building stronger, connections to recovery, as well as placement into recovery housing, and whatever other resources they need around their ongoing pathway of recovery. As part of that recovery support navigation kind of side of the house, or from that framework, we've built really strong relationships with the town of Yarmouth, which we have had a longstanding grant with them as a community to work alongside their law enforcement and their victim advocate service to provide support for individuals who have come into some form of contact with Yarmouth Police Department, regardless of what the call has been. If there's kind of a thread of substance use somewhere infused in there, we reach out as a team, again, an individual lived experience, to that person to try to offer up opportunities to, again, move forward with their recovery, or if nothing else, to build rapport with someone who is trusting and willing to better understand their unique experiences and support them with navigating, the resources that are out in our community. We also have a grant with Barnstable County to provide recovery support navigator services to pretty much at this point individuals from any one of our communities across Cape. It's an expansion from a grant that we had with Dennis previously, where we were doing something similar to Yarmouth in the town of Dennis. And another thing that I'm really excited about is we have built an incredibly strong relationship with Barnstable Police Department's community impact team. So we work alongside, their officers. I have a fondness for Danny St. Peter, just because we get along very well. And we really try to meet with folks in the community alongside them, if we are able to, as we're integrating ourselves into our patient care, to truly meet folks in the community and where they're at, rather than needing to either send them directly to the hospital if that maybe is not their need set, or putting someone at risk of kind of moving down a path where incarceration or arrest is going to be the future next step in their path. We try to intervene and to support in that capacity as well, with continued and targeted follow-up. So that's kind of our recovery support navigator program in a nutshell. Moving forward, we have seen that brief intervention, even though it is an incredibly important part of our work, in trying to link folks to treatment and support them with, navigating a very fractured care continuum, not just regionally, but across Massachusetts and the United States, that we wanted to expand past our four walls at Duffy. So we've worked really hard with, again, key stakeholders in the community and at the state to integrate true recovery coaching into our service line. So we have at this point 7.5 recovery coaches that work specifically with our patient population, as well as a couple of service lines that I'll talk a little bit more in depth about that go beyond just our patient population at Duffy, with the intention of working with individuals for 6 months or more outside of the facility, meeting them in the community, home visits, attending whatever, again, their pathway of recovery is for them. That may be 12-step meetings, that may be attending refuge recovery, going to the gym, building wellness plans, et cetera, et cetera, et cetera. Recovery is not one size fits all. In making that a unique plan that fits for them within our towns has been beautiful to see, and continuing to navigate a return to use or relapse, and figuring out how to have those warm handoffs and to continue to track folks. That's been a really important part of the fabric of the work that we do as well. One of the programs that we're really proud of and came from recognizing that one of the most marginalized groups that we can serve on Cape, in addition to folks experiencing homelessness and our LGBTQ and communities of color, are pregnant and parenting women. We know that pregnant and parenting women are a group that is incredibly high risk for relapse, overdose, and death post-delivery. So we have had our Moms Do Care program, which serves pregnant and parenting women. Originally, it was just for opiate use disorder. Within the last year, it's expanded to for pregnant and parenting women with any history of substance use disorder, where we pair clinical with peer support. We have 3 recovery coaches, again, strong, independent women who have lived experience, are parents, and are able to help navigate the multitude of stressors that come with early parenthood, as well as navigating systems such as DCF. We have a full-time therapist, which not only works with that specific population, but we've also recognized that there are other gap areas in our community that, again, stretch beyond just substance use, which include perinatal mood disorders. So this clinician does work specifically with folks in recovery, but has started facilitating mental health support groups for women in families, regardless of your history around perinatal mood, anxiety, depression, et cetera, in Falmouth as well as in Dennis, and also having a care coordinator to help navigate, again, treatment on Cape Cod. And then the other program that we're very proud of is a partnership with Behavioral Health Innovators on Cape Cod, where we serve teens aged 13 to 17 who have either somewhere between the mild to moderate, lower high risk substance use disorder, where we provide 2 nights a week, Monday and Wednesday in Falmouth and Tuesday and Thursday in Dennis, group-based treatment. One, to build insight and a better understanding into what substance use disorder is, how that impacts them, as well as building a social support network for these adolescents with others who are making strides, hopefully, towards their pathway of recovery, whatever that means to them. So that program has also expanded within the last year and a half. It went from a small kind of skeleton crew program to being a program that is now facilitated by, it has a program manager, a full-time therapist, a full-time recovery coach, a full-time behavioral health specialist, young adult behavioral health specialist, as well as a part-time family therapist to help support caregivers and loved ones who are trying to figure out how to continue to integrate treatment of substance use within the home environment. So, that is a program that, again, has launched, and we work very closely with school systems, DCF, and other allies to try to serve that marginalized population. And then I think the final thing that I want to say on a substance use disorder level is this work obviously happens within our walls, but would not be possible without the really close connections and relationships we have with our community allies. We work really closely with AIDS Support Group of Cape Cod, our sister community health centers, Gosnold, the hospital, Roar, who has supported us with funding for recovery housing for our folks who are coming back into the community. The list goes on and on and on. In bringing the work we do to the region and embedding ourselves again with the RSAC, as well as just being in the work itself, our dedication is to really shift to meet the needs acutely of the community, and in any way that we can do that with you folks and to support whatever goals you have, we are very excited to be available and supportive of your ventures as well. So thank you for allowing me to speak about our services.
Thank you for coming to speak with us. So anyway, I always like to leave my questions till last, because usually I find committee members or commissioners, wherever, will answer the questions so I can knock them off my list. So, if it's all right with you, I'm going to ask any of the commissioners, if they are committee members, if they have any questions. Is it all right if I say to any of the three of you? Do you mind? So they could just direct them to either Aaron, Daniel, or Sarah. If you could put your hands up, or yes, committee member Scott Fitzgerald.
First off, I'd like to say thank you to the three of you for joining us tonight. I did have a question that I guess I'll throw Sarah's way. However, you can toss it to others, and it's only because you specifically mentioned it in your presentation. Specific to homelessness outreach services, could you talk about how that occurs in greater detail? Because you referenced the hidden homeless and having outreach folks working on the streets and in the camp. So could you talk about how you specifically identify how that occurs? How are your folks getting out there and engaging folks that may be in the camps and in the streets? Because oftentimes they may be the most resistant or difficult to engage.
Yep. Thank you for that question. So I'll start and then ask Aaron and Danny to chime in if I'm missing something. So we have a handful of outreach staff that have been with Duffy for a really long time, and have over time developed relationships literally by just, I think many years ago they would just go into a camp. They don't do that anymore. They'll go with one of our community impact unit team members to talk to folks, to get to know them if they don't know them already. They have established relationships with a lot of the folks who are reticent to come into the clinic for care. There are a percentage of folks who are living on the street who are living on the street by choice, and will not seek shelter, may not be able to access sheltering services for various reasons. And so the goal of our outreach staff is to stay connected to see how they can get folks to come in, if they can get folks to come in for services, and to see what they may need acutely to be connected to. I'll share two stories. We were doing a rebrand on our website, and we were talking with the creative director about something related to content. And we were talking about our folks that go out to outreach. And he said, how do they know when to stop? And I said, well, they don't stop. and they really don't. Right. It's really extraordinary. I'll share another story with you. The gentleman that started Homeless Not Hopeless, who preceded Alan Burton, his name is escaping me, was living in it. I'm sorry?
Dr. Levine.
Yes.
Yes.
On in a camp for years. And our first employee, Cindy Glista, who's a nurse and still there, would go out every week to see him and check in on him for years. And he shared during a homeless person memorials service, probably more than a decade now. He said, she kept coming out. She'd come out like in her long skirt and check on me. And he said, and I would just run from her. And she would come every week and I would run and run. And he said, and one day I decided to let her catch me. And that was the day he decided that he wanted to get sober. It was the day that he didn't want to live at a camp anymore. He wanted to get better. And she had established that relationship by just showing up. And so that's anecdotal and maybe more than what you're looking for, Scott. But that it's literally going out and walking into camps with our community impact unit partners who also have relationships with our folks who are living on the street. And that makes a huge difference. That social component and that model and that relationship building is really unique and is something that our staff are really, really good at. And that's how we get people to one day decide that they want to get well. Danny and Aaron, I don't know if y'all want to add anything to that.
Yeah, I'll add a few bits and pieces. Sarah, I think you hit the nail on the head with that. I would also say, I'm a Cape boy, born and raised, escaped for about 10 years, but Falmouth boy, Mashpee man. And I think that, we've seen even how what homelessness is on Cape Cod has shifted even, in the last 10 to 20 years. I think that, the quote unquote good old days of knowing that an encampment was behind said location is no longer the fact. They are more sporadic, they're more spread around. There is, mistrust sometimes from, some of our most acute individuals who are experiencing, the most complex diagnoses of mental health and substance use, that it becomes more challenging to find folks. So when Sarah talks about building rapport and building relationships, not just with community partners, but the community itself, is that as folks become comfortable with working with our team members, who many of them have the lived experience, many of them have been in those positions, many of them have struggled with substance use and have had to make really tough decisions on where their housing is, right? So you're looking in a lot of ways in a mirror when you're talking to one of our team members. And that level of comfort provides opportunities for folks to allow our staff to be more welcomed into some of these more private and sensitive areas that may be very much so off the grid to others, right? And that comes with, at times, like Sarah said, days, weeks, months, years of building connections until someone feels comfortable enough to finally say, yeah, I live in a boat behind said place, right? So I think that is a major piece. And then I think the other thing that I will say related to that is, in building relationships with law enforcement in a lot of ways, we've had really great relationships with, let's say, the town of Yarmouth, where some of their natural resource officers, in collaboration with their police departments, kind of have a lay of the land of where individuals may be staying, and we go out as a team and help to support around discussions of that. So it is a really community-based effort, and not giving up is ultimately the answer to how to engage individuals. So I agree with Sarah 100%. So thank you.
Awesome, thank you.
Yeah, and just to add one thing, I agree with what Danny and Sarah said, and I think it's important that people trust Duffy as an agency too. So, people that are experiencing homelessness, they have a community too. So if someone they know that also experienced homelessness got connected to a case manager and it was successful, then sometimes they trust that word in the community and their peer over another resource. So I think that us showing up. You know, there's community events weekly. There's a coffee house that Duffy attends to. The RSNs and case managers go. You know, Sarah talked briefly about a spiritual provider that provides some community outreach. But also Duffy provides, and through marketing, letting people know and let community know, we provide some basic needs stuff so people can come here and get a shower. And, you know, that basic need, if they just come and get a shower, that's a connection that and a basic need that will hopefully eliminate, you know, my behavioral health lens, some of those anxiety and depression symptoms, like Sarah said. If you can't really deal with your
right
trauma if you're continuing to experience not being homeless or not being able to shower. So yeah. I think Duffy is trusted in the community and trusted in that community too.
Fabulous.
I agree. Were there any other questions? I just better check. So State Representative and Committee Member Stephen Saros.
Yes.
Did I get it right this time, I hope?
Oh, that's okay. As long as you come close, or just call me Rep X. Makes it easy. Rep X.
Oh, I like that. Okay.
Yeah, Rep X. Makes it easy. Not really a question, just I'm so proud of you guys. I can see the passion. You love what you're doing. It's important, critically important. Everything comes off of this subject that we see. You know, being a cop for 40 years, we saw it all. And then we saw how to work better with people in the community. And I love what you're doing. So, you know, as a former police officer, as a current state rep, as a Gold Star father, I love what you guys are doing. And come to me if we can help statewide. But also, you know, for the town of Barnstable where I live, that's what this committee's all about. And you know, Carlos knows, we all know, like I've been to the St. Joseph's home. I've been through it. I've brought food, clothes. You know, it's wonderful that it's there, but you know, it needs work. And we don't have enough room. So there's a lot going on. I appreciate what you're doing. I just want you to reach out to me as a friend and a supporter, and let us do what we do to help you. Because, yeah, if you could be out of business in 5 to 10 years, I get what you're saying, Sarah, but you won't be, because this problem goes on, but we can make a huge impact by working together. And I think sharing our knowledge and not just talking, but doing.
I agree entirely. Any other committee members have questions? Commissioner Carlos Barberson.
So I just want to put myself available to you folks too, because if any possibility that you have someone who doesn't speak Portuguese and Spanish, I'll be here to help out with anything I can. So it's a great job that you guys doing. I really appreciate that.
And Carlos, I have big plans for you. And also, I wanted to talk with you about a person you said that speaks four different languages. But we'll have that separate conversation.
5.
Oh, I'm sorry, 5.
Not me. I'm speaking.
I know. It's part of the plan, so to speak, that I want to suggest. But anyway, we'll have that conversation separately.
Well, actually, I just want to mention that Duffy know Michael Messinas from the community health, for the health minister, so they know that. So,
any other committee members have questions before I put mine out there? Okay. Can I ask Cynthia if we have a hard stop at 6:30?
No, Madam Chair, you do not.
Okay. So, few questions I have, and thank you, fellow committee members, for tackling a few of them that I had. Sarah, the Duffy was dealing with Noah Shelter that is now St. Joseph's. So you're still working with St. Joseph's, is that right? Or what does that connection actually look like?
Yeah, so thank you for the question. We, to my knowledge, have not started going back in before. before COVID, let's harken back a few years ago, before COVID, one of our nurse practitioners would regularly go over to the shelter to see patients there. It's considered one of our sites. But post-COVID, to my knowledge, we have not started back providing services on site at the NOAA shelter. We still have a very strong relationship from a community partner perspective, but as far as the on-site services is not something that we've started back. Does that answer your question?
It does.
Okay.
Next, did I hear you correctly? You have the 501c3 status?
Yes, we were incorporated in 1997. Last year was our 25th anniversary, and that's when we were established as a 501c3.
Okay, thank you. Another thing, you were talking about the various categories and percentages and that, which all added up to 100. But do you, in the at-risk categories, you also, I believe, just to clarify, you treat the people who are not, I mean, everybody's at risk for one thing or another, but the people who are just there for straightforward mental health, not just the at-risk categories, but like grief, regular mental health, what I mean regular mental health, relationship issues, anxiety, depression, and all that kind of stuff. You also treat that as well, do you not?
Yeah, I'll punt that over to Erin since she's the director, but
okay.
Whatever.
Yeah, we deal with any mental health diagnosis. In order for an individual to receive psychiatric services, to see a psychiatrist, they have to be a primary care provider and be seeing a therapist, but they can just get straight therapy. They don't have to be a primary care provider. We focus in our population on those with mass health, Medicaid, Medicare, underinsured, not insured patients. Currently, we don't really focus on the private insurance currently right now. We just focus on that towards our mission and values, but we do support any mental health or substance use diagnosis.
Well, that was the next question, actually, and that was, you had mentioned the other insurance. Do you not take commercial insurance?
No, not currently.
Okay, just wanted to clarify that.
Just to clarify with Danny, I'm not 100% sure on the substance abuse programs because some of those aren't insurance based. So, but in behavioral health and psychiatry and Sarah for medical, right? No commercial insurance, but Danny, some are grant funded, so that's a little different.
Okay.
Go
ahead.
Oh, sorry. I was just going to say, for our OBOT services, which again is the medication support and treatment, that follows the same line of insurance coverage as the rest of Duffy Health Center. For folks who are referred to us who may not fit within that criteria, we work really closely with our community allies to have warm handoffs and ensure that they get into the appropriate treatment centers. But programs like our Moms Do Care program, there is no insurance. It's not insurance driven. So we serve members across the community. Similarly, our teen program, Alternative Peer Group, not insurance driven. That is a grant funded program through BSAS. And our Recovery Support Navigator services, again, being grant funded, we do support folks in a multitude of different ways, regardless of socioeconomic and insurance status.
Okay, excellent. So one other question, and that's actually for you, Daniel, actually two more. How do you differ from Gosnold? You work closely with Gosnold, but you do very similar things, but how do you differ from Gosnold?
Yeah, so again, Gosnold is a really strong community partner. In a lot of ways, it's apples and oranges in some ways, and yet we have a lot of overlap in the sense that, historically there's primary services, kind of started with supporting folks through detoxification, providing inpatient care for individuals who need to go through medical treatment, for their withdrawal symptoms. So that would be their, site in Falmouth. In addition to that, I think as a community, we know that they've had some transition over time, but they do provide residential treatment or had been providing residential treatment through their Katomet program, as well as CSS and TSS, which is more of the acute stabilization programming, when, through Emerson House, as well as Miller House when they had that. So those are more of the structured treatment kind of housing perspectives. And we're actually very lucky because Miss Erin came to us from Gosnold, so she can also speak to that as well. But their outpatient services, I'll let her speak to the behavioral health end of things, but ours are really rooted more around, I would call it in my terms, like the grassroots, on the street, community engagement, connection, support, resource, like getting your hands dirty of like being out and about and really trying to meet folks where they're at. Where they do have a component of that with their recovery coaching services through Gosnold. But a lot of their outpatient clinics are office-based clinics, as well as SOAP, which is more of a like group-based treatment model for individuals experiencing substance use disorder. And Erin, since you have much more knowledge than I do, please fill in as you please.
I think one difference is, like Danny had stated before, the RSN and recovery coaching programs are grant funded here at Duffy, where at Gosnold, they are insurance based. So the criteria for insurance and grant are different. I didn't oversee those services when I was at Gosnold, but my understanding is Mass Health has a certain expectation of what should happen. Like they need to have so many touches, whereas a grant, I think, offers more flexibility to have kind of think outside the box a little, where insurance kind of limits you in some ways. And in like our previous question, Gosnold does in their outpatient services service commercial private insurance. They have a partial hospitalization, which focuses on the mental health and co-occurring disorders. But they do also, like Danny said, have the inpatient services that Duffy doesn't have. And unfortunately, like we've discussed, I think there's a lot of need and a lot of people that need these services. So we're grateful that other people are also providing these services on Cape Cod, because we can work closely to collaborate and help these individuals as much as possible.
Okay, thank you. One last question for Danny.
I want to ask a question.
I'm sorry, Carlos, go ahead.
Is any relationship with NAMI?
Sarah, I don't know if you want to take that.
Sure. So we have a suicide prevention program that is led by our spiritual care provider, and maybe Erin can share more about this. But there is a relationship between NAMI and our suicide prevention program. Erin, I don't know if you have anything to add about that.
Yeah, I mean, we work closely with a lot of community agencies that we've talked. I don't know if I stated this, but I recently came to Duffy from Gosnold, and I worked with NAMI there, and also have reached out numerous times to the executive director over at NAMI. So she knows that we're support for them as they are support for us. So I think we have a supportive relationship.
Okay. One last question for Daniel. I was curious, and I love the community impact team. The whole concept of that. We had that also from Chief Sonnabend was talking about it. Fantastic. How do you have 7.5 recovery coaches, or did I mishear that?
We just have one really, really short recovery coach, so we count them as a half. So I go by, sorry, I should have been more specific. We go by FTE, so full-time employment. So the 0.5, the half-time person is actually, we have a relationship with Community Development Partnership out in Orleans, where they have a recovery home. It's actually their canal house. So we have a halftime recovery coach who specifically serves just the residents of that house. So we wanted to create a more unique recovery home experience, unlike other sober homes on Cape Cod, where, you know, it's really a residence with a house manager, and expectations for recovery beyond house meeting and urine drug screens is you kind of run your own recovery. And you're expected to be accountable for your own recovery, which is perfect. But in being able to have an embedded recovery coach within the home, it provides more guided conversations around what that unique residence pathway is, while also creating wellness plans, relapse prevention plans, and continuing to provide consistent weekly check-ins to ensure that if there are any hiccups or speed bumps in that person's pathway, they can be supported and addressed. So in a case example of that, which is really silly, like a gentleman was struggling to get employment, which would have put his housing in risk eventually, right? Because, you know, he needs to be self-sustainable in that home because it's a subsidized program outside of Duffy's scope. So the recovery coach supported with finding I don't want to say it's grant funding, but like mass funding for an electric bike. And they both went to Provincetown to go find the last electric bike on Cape Cod that was appropriate for that funding. And they got it. And then he got to go to work. So it's initiatives like that. And if it's okay, I just want to say one specific thing to Mr. Carlos. You know, one area in which, especially around substance use disorders, we know that our non-English speaking and communities of color, even though we're a pretty homogenous population on Cape Cod, those are some of our most underserved. So we're always looking for more diverse lenses. As someone who's also trilingual, I have to say I am encouraged and excited at any partnership opportunity to figure out how to better serve our Portuguese, Spanish, you know, native community members and beyond, Cape Verdean, et cetera, because we know that these are some of our most marginalized groups that have been less served on Cape Cod. And we're always striving, as Sarah had said, even from our mission statement, to do our best to continue to be culturally humble around serving, you know, our unique populations across Cape Cod.
Thank you so much.
I'm sorry, Cheryl. I really appreciate you saying that. And if you allow me to, I'm going to gather some people and visit you soon. And some people who are going to provide you with some service too, with the translations and things like that.
So can I State Representative and Committee Member Stephen X.
Thank you, Madam Chair. I mean, we could go all night. This is really impressive.
Right.
I just wanted to throw three things out there. Sarah, especially, maybe, you know, St. Joseph's Home. God bless them that it's there. The workers are amazing, but the place is run down. And you know, is it better to be there than out on the street? Yes, but people shouldn't have to live like that. So it's clean, it's healthy, but it's worn out. You know, it needs painting, furniture, all that stuff. So if there's anything you or I could do with that, I'd love to see the people that are there treated to have a better environment. The workers deserve it, and the people deserve it. That's one thing. Number two, if you guys have any law ideas, you know, funding, obviously we do everything we can for that as a delegation. But if you think of a law that hasn't been filed or that should be filed, you know, come to me, because we have 2 weeks to do it in the next 2 weeks. Some type of law or laws that would help you in what you're battling. Not just funding, but a law.
Why 2 weeks?
That's all we have. We have a 3-week window to file laws. Starts January 5th and ends January 20th. There will be 7,000 bills filed by the 200 elected officials. So it's massive. But I want to get mine in there, especially if there's a law that we can fight for that can make a difference. please think of that and let me know. And then lastly, I wanted to ask about the new behavioral health hotline that's supposedly brand new that people can call and a team comes out and helps them. Can someone talk about that if you don't mind? Thank you.
I know there's one with Cape Cod Hospital. Was there something that Duffy had mentioned that you wanted to hear about?
No, this is a brand new state program that's out there. So I was wondering if you've dealt with that yet or know anything about it.
Are you talking about 988 or are you talking about the new behavioral health hotline that Beacon is running?
The new one, yes.
Yeah, so
Beacon? Okay,
yeah, it's being run by Beacon. I know that, and similar to 988, I think it is to connect people to resources and to needs, behavioral health needs, and they also can connect to the new community behavioral health centers. So for the Cape, that is run by Bayco Human Services. So if you call the behavioral health hotline that started on the 3rd, I believe, they will do a brief assessment, assess needs and what their treatment goals are, and then refer them out as needed to. So I think it's similar to 988, but 988 is that line is like Cape Cod Samaritans is now running that line on the Cape, where Beacon I think might have more of a clinical lens is my understanding. Don't quote me on that, but I think that's my understanding. But they both can, 988 and the new behavioral health hotline can connect people to emergency services if that is what is needed.
Steve, I will have a full answer for you for the next time.
Wonderful.
It'll probably be, I'm almost done with that packet. I've got half of it done, but I wanted this tonight to be included as well.
Thank you.
Any other questions? If not, let me just check for hands here.
Mr. Rodriguez has his hand up.
No, he has his finger up, but go ahead.
Well, I was just going to add, and this is slightly off topic, but since State Representative brought it up around hotlines, there is also a hotline in Massachusetts. It's for folks who may be illicitly using or just using in general, who may be at risk of overdose, who may not be around anyone to, kind of be a support person if for some reason they were to have an overdose. So it's never use alone. So it's man and womaned by individuals who are able to remain on the line with individuals as they kind of go through that process to ensure that they are using in safety. Because in the harm reduction world prior to COVID, when folks were getting feedback from support services like AIDS Support Group of Cape Cod, it was never use alone, use with a buddy, use with someone that if it's laced with fentanyl or something and you have a unexpected overdose, they will have the tools necessary to support you with Narcan, etc. So that is also a resource that I think definitely needs to be more embedded in our community across the board.
Okay.
Cheryl, the last thing I have to, can I say something last thing here?
Go ahead.
I just want to, Steve gave me 10 winter coats 2 weeks ago to distribute to the homeless people. And Steve, I did that. And the reason I don't have pictures is because I don't want to invade their privacy. So you know, okay? Thank you very much.
Oh, Carlos, yeah, we're going to do a lot more. You'll see.
We most certainly are. So, I wanted to thank our
Sarah has her hand up.
Oh, I'm sorry. Sarah. Oh, yes, your hand is up. I'm sorry. I missed it.
Please. No, that's okay. I just wanted to share a couple of kind of final thoughts, but if that's appropriate.
Absolutely. Go ahead.
For the committee. So I understand I think I understand where the work that you all are doing and the direction that you're moving on making recommendations to the town. I think what you've hopefully seen and learned through our presentation tonight, and I'm sure through other community partners that have come before you, is all of these intersections of housing, housing economy, mental health issues, substance use disorder issues, which are not unique to us, right? It's not unique to the Cape, but are super complex standalone and are even more complex when they're integrated, right? It's this constellation of issues, all of which need to be pressed and touched at some point in order to come up with not just solutions, right, Steve, but actual action around the solutions. I would offer that we're in a climate where being a leader and being creative are really important. I would offer, I'm not from the Cape, but I live in Barnstable and I've been here for 13 years. So I will say, I think Barnstable has always been a leader in our community around, through our town manager's leadership and our council's leadership around housing development, looking at these community needs and coming up with creative solutions. So I would offer to this committee for consideration as you put your recommendations together for the town council. Finally, I would just offer that you've probably intimated from some of the, or inferred from some of the conversation we've had tonight are barriers, right? So we have barriers and access issues related to housing. I've been in conversations with, when we got the ARPA money and what are we going to do and how are we going to, everyone at the housing table is sitting around a table and I'm waving my hand saying, our patients aren't even there yet, right? Like we can't talk about homeownership programs like the Habitat for Humanity can, because our patients are way back here. We need steps to that access to housing, and we need layers of housing opportunity. We need workforce. We need to move away from, the 1 acre single family property, but we also need layers around that to step people into safe housing situations. We need more access and better oversight of sober houses. We need more access to substance use disorder treatment services here on Cape. We're sending people from our community off Cape because we don't have anywhere here. That means we're taking people away from, we're not taking people, people are leaving their families and their networks and their connections behind in order to get healthy and come back to our community. How can we be creative about solutions that people can access here at home instead of maybe a singular provider here on the Cape, or the alternative of sending people away for 3 months to come back and reintegrate is really, really challenging. So I offer that to you all because I think there's an opportunity to be creative, and we're at this sort of fever pitch, this apex of opportunity. So how can your recommendations reflect that and inform the council and town officials to be able to move forward in some solutions that we haven't yet seen here because we haven't had the chutzpah yet. So thank you for listening to my TED Talk.
Sarah, you and I are very much on the same page. And before I present with the next thing, I may well contact you to run by you possibilities and what you're feeling them. Okay, so I don't see any other hands up. I want to thank everybody for their input. Thank you very much to our 3 speakers that we had tonight. It's very valuable information. In answer to Sarah on some of the things you're talking about, yes, what I've tried to do is to particularly engineer, because as you said, it's not just all one section. I've tried to highlight the various areas. We could do this for an hour every day for 2 months, but the thing is to try to get the key resources that are kind of well involved with the various different areas and to put together a possible proposal that takes in all the things that have been highlighted by not only the speakers we've been honored to have, but also by the committee members who have voiced what they feel as well, and to try to put together some sort of potential solution. I want to thank you for speaking. You're welcome to stay. We're only going to be a few more minutes, but you'll see where we're going with it. And I wanted to just, because we've already taken over the time, but that's fine, because I think that this is valuable, extremely valuable information. I did want to see if there's any public comment. I have checked. I don't see anyone that looks like they're in a waiting room or anything, just so I've addressed that particular issue. Cynthia, is there anyone in a public comment?
No, Madam Chair, there is not.
Didn't want anyone to be sitting here through this and not, I want to speak and then find out we didn't address that.
Sure. You
Yes.
mind if I add something what Sarah was saying?
Sure.
I want to add the halfway house. The sheriff of town of Barnstable should create a halfway house. People coming out of jail, they have no place to go. They end up being in the streets. So I think it's very important to mention that to you. So.
That's part of, you'll be very pleased to know that that's already part of what I was going to suggest.
Okay, so, good then.
I worded it a little differently, but same purpose. So by the next one, as I said, I'm halfway through giving you the information, and thank you, Sarah, correct me if I'm wrong. I have permission for those slides. You'll send them to Cynthia and I can send those slides out. I'll also attach the notes that I've been taking. I'm up through August on breaking down everything of the people who have presented and typing that out. I will get that to Cynthia. I'm sorry, Cynthia, but Christmas holidays and New Year's and that wonderful tax return I had for my property taxes kind of put trying to I got sidelined. So anyway, probably inappropriate, but that's what I'm going to do. I'm going to put all that together, get that there. And then Sarah, I'm going to probably give you a call about a couple of the things, if that's okay. And
sounds good. Thank you.
And then that's going to be, what I was going to say something that went right out of my mind. Oh, I know. Next thing is approval of the December 13th minutes. Cynthia, you did a fantastic job on that. Any comments from any of the committee members? Any changes or anything?
No.
Nope. Okay. So there's nothing, no items unexpected by the chair. Okay, so
do we need a motion? Do we need a motion to approve the minutes?
We do. That's the next question. So would somebody like to make a motion for approval of the minutes as they are?
So move.
Is there a second?
Second.
Okay. Commissioner Liz Roberdeau?
So I abstain. I wasn't at that meeting.
Fair enough. Commissioner Scott Fitzgerald?
Yes.
Committee member Kim Crocker-Crowther? I think she had to go out. Committee member Steve X. And
yes.
Thank you.
Yes.
Committee member Carlos Barbosa?
Yes.
Okay, I also say yes. So those are passed. Anyway, apologies for the comment. And is there a motion to adjourn?
Well, actually, I want to ask Cynthia a call. Is any way the town council is going to have somebody be a liaison with us here? Or?
Yes,
we do.
You currently have Councillor Lutke from Precinct 3, but she's had some health issues, but she will be attending the next meeting. Okay. So yes, and she gets all the agendas and meeting minutes from our prior meetings, so she's kept up to date. And she does apologize for not coming to the meetings, but she's had some health issues.
Thank you.
She is absolutely fabulous, and we're very lucky to have her. We really are. So yes, she did attend our last meeting, I believe. Did she not, Cynthia?
She did. She did, and she will attend the next one. Yeah, she'll be at the next one.
Yeah. I have spoken with her about what we're trying to do, and she She's absolutely fabulous. We're so lucky to have her. Anyway, so we've copied through it. We've approved the minutes. Is there a motion to adjourn, please?
So move.
Second?
Second.
Thank you. Commissioner, committee member Liz Roberdeau.
Yes.
Committee member Scott Fitzgerald.
Yes.
Committee member Steve X.
Yes.
Committee member Carlos Barbosa.
Yes.
I also say yes. That is unanimous. We are adjourned with many thanks to our speakers for tonight. I think that's very informative.
Thank you so much for having us.
Oh, and
God
thank you,
bless you
Cynthia
guys.
Lovell, for all your hard work. Much appreciated.
That's right.
Thank
You're
you.
very welcome, Madam Chair.
Okay.
Thank you.
Stay safe.
Okay, thank you.